Okay, hello, I am Jeff Fisher. I would like to speak to you now about the nature of spinal pain. My purpose is to develop the notion that there is such a thing as protective behavior and what it means in terms of treatment and assessment, and perhaps even more importantly, associated pain problems, musculoskeletal pain problems, and ways to consider them to be possibly referred pain. So I've been a physio now for more than 25 years or so, and in that period of time, early on anyway, I was very frustrated with the methods that I'd been taught. So it occurred to me that there had to be something better. So progressively I found that I applied myself according to the Maitland model of mobilization of spinal joints, which of course I'd been taught and most Australian physiotherapists are. But I found that it presented a few problems in that it was time consuming in the fashion in which you were required to do active movement tests to perceive change. Along with that, a few other things which I found that just weren't up to what I hoped would be true of a method that had been offered to me as a way to treat spine and treat spinal pain and spinal stiffness. So I gradually, progressively applied myself to doing more and more of it, in other words, more of the mobilization itself, to a point where I then realized that the best effects of mobilization could be, under some circumstances, gained with more and more and more and more, until a point was reached when I was commonly mobilizing spinal pain, in other words, places in people's spines which were perceived either by them or by me to be less than perfectly mobile and sore, and pursuing them with gentle, careful attention to the resistance that I found to be true of spinal joints, to the point where ultimately that resistance dropped away. And so ultimately, as the resistance dropped away, pain dropped away as well, and a whole range of other normal features reasserted themselves to people's spines. And also, even more interestingly, to what I could then offer up as what was evidence that referred pain had been taking place to people's limbs, their knees, their hips, etc., etc. So eventually, over a period of years, I pursued this method, not entirely to the exclusion of all others, of course, but in the realm of musculoskeletal problem solving. What I discovered that was that most people who came through my door either had spinal pain problems directly that they would perceive as spinal problems, or they had musculoskeletal problems that I would then go on to discover were in fact related to their spine in terms of these protective behaviours I mentioned. So I just want to outline, and without the benefit of my usual blackboard up here, which you'll have to just imagine, this is not blackboard, this is my most recent painting, by the way. I call this the neuromatrix. So just want you to imagine that spinal behaviour I put forward can be said to have protective behaviour, that your spine is endowed with a means whereby it limits the range that it will move through, and by doing so limit also the threat applying to it. So this is a primitive behaviour, it's an instinctive, hardwired behaviour, and some of the evidence that we can see that this may be true is that, well, when people complain of spinal pain, by and large they're stiff. They can't reach, they can't move, they can't bend. Limitations apply to all kinds of flexion and movement and extension of their spine, rotation, etc. And that they will often perceive, these people who complain of pain will often perceive that their range is limited. And so muscular tightness is a feature of spinal pain. So what I propose is that muscles that are intimate to spinal joints are capable of a range of different tones, and we already know that this is true, but the tones that are capable of reducing range of movement in order to protect the spine. So what I propose is that there's originally a threat, and the threat might be trauma or it might not be trauma. Commonly it's fatigue. Fatigue is associated, for instance, with long periods of sitting and doing the same thing, such as might be true of a person at a computer. Either way, when the threat is perceived by the brain, then tone increases around that area of the spine under threat. As the tone increases, fatigue follows. Fatigue will offer up its own range of nociceptive stimuli. The brain relates to that. The cycle of feedback occurring ultimately leads to more and more tightness, more and more tone increases, and there the result is less and less movement. So eventually the point is reached where movement is insufficient to provide the necessary physiological normal stimuli for joints. In particular, I mean synovial joints, facet joints within the back, within the spine itself. So my interpretation of what then takes place is as follows, and I offered that it's an interpretation, not that this is absolutely definitely how it is, but it seems to me that this is a logical way of interpreting what takes place. So synovial joints have of course got synovium inside them, which is both a friction-proofing liquid and the means whereby oxygen is made to flow over living tissue, cartilage tissue. So if that is limited, if the facility for the flow of synovium over cartilage is limited by compressive forces, muscles in other words protecting that joint, then there will be less facility for that oxygen flow to take place. It follows then that the joint must do something about it if it can, and the process whereby it keeps itself alive involves inflammation. Inflammation is a trigger or a stimuli, and that stimulus causes the synovial membrane to manufacture more synovium. And under that circumstance, provides for the joint over a long period of time, even though protective tightness continues to occur. The inflammatory event of that joint, however, adds to the stimulus already taking place by muscle fatigues, etc., to cause protective behaviour to be further locked in. And ultimately, it serves that purpose, the purpose really of a successful protective behaviour, because it limits threats still further. Now, a third level of that same protective behaviour can be said to occur when the nerves intimate to facet joints, nerve roots in fact, within the spondyle, are also involved in that inflammatory event. And simply by proximity, it's reasonable to expect that minor inflammatory irritants take place to those nerves which have soft tissue surrounding them, which are entirely capable of being inflamed themselves. And so the chemistry of inflammation involves those nerves and gives rise to all manner of altered states related to that nerve. One of which is pain, perceived by the brain. Another will be altered patterns of recruitment associated with that nerve root. So local to that nerve root will be, of course, many muscular structures and others, but muscles in particular, associated with that loss of movement, such that by incorporating larger muscle groups distal to the spine, it further magnifies the success of that protective behaviour. For instance, if the muscles of the neck, intimate small muscles of the neck, the first level of which of course are only about that big, within and around and adjacent to facet joints, primarily they're involved in the first level of protective behaviour. There are two other larger groups of muscle that ultimately may be involved. As they are progressively involved, if that happens, it's associated with greater and greater levels of pain, perceived again by the brain, associated with muscle behaviour that is, they're physiologically different types of muscles from those smaller intimate muscles, which are quite capable of long periods of extended and quite powerful tonicity without necessarily breaking down under the influence of their own metabolites. This is not the case, for instance, of larger phasic muscles. So phasic muscles, as you know, capable of short bursts of intense activity, but they're also capable of pain associated with that activity by virtue of metabolites that are not well flushed and buffered, etc. So the whole picture, I guess, that I'm suggesting to you is emerging, which is that your spine has this wonderful capacity for protective behaviour that is ultimately successful if it keeps you still, keeps you from doing stuff that was perceived to be threatening to your spine. So what I saw fit to do and to reason as I kept doing the mobilisation treatments that I did early on in my career was to attempt to understand, well, why was mobilising useful? What was happening to joints and other structures and nerves, etc., that would see a reduction in that tone and a restoration of normal movement on a regular basis without manipulating, stretching, exercising, or any other treatment at all. I was able to regularly, repeatedly offer up useful treatments that had long-term value without any other form of treatment at all. And I continue to do so. So it occurred to me, well, I'll try and understand this. Excuse me while I have to blow my nose. Attempt to understand this. My attempt to put forward some known physiological understanding and context and perceive it not to be, perceive spinal pain not to be disease-related, because I maintain that it rarely is, but to be protective in its nature. Excuse me. So ultimately, the method that I continued to do became known as CM, or continuous mobilisation. And commonly what I'll do is stick my thumb, one of this pair, normal thumbs, quite sensitive things, quite powerful too if you practice, and by moving structures as close to as I could get to facet joints and perceiving resistance to that attempt to passively move, noting that that resistance was associated with pain, and in the individuals for whom this occurred, in other words, those two criteria were occurring at the same time, resistance to attempt at passively moving a spinal joint and pain at the same time, I would describe that event as a protective event. In other words, protective resistance was taking place that I could or wished to negotiate away. So what I find is that in most cases, in unimpaired, undiseased, people with no trauma recent, that in most cases it takes between 20 and 30 seconds of continuous mobilisation at a rate of about 2 per second for that resistance and that pain to drop away. Until ultimately, if I continue on, which might take ultimately possibly even 5 minutes, or even longer in some cases, but in most it's about 1 to 2 minutes. If I continuously mobilise at that one place and perceive resistance dropping away, pain will also drop away until it's negligible. At that point I can say we've got resolution. Resolution to what was a protective behaviour associated with that joint and with that movement. So what's really exciting, however, came as I continued to do this, which was to discover that many of the kinds of musculoskeletal pain problems that I'd been taught were mysterious in origin, and that previously, or at least even still now, have treatments that I believe are inappropriate, in that what I routinely discovered was many of these musculoskeletal problems would just disappear. When I had successfully negotiated away protective behaviour at the associated neurological level related to structures in the leg, arm and so on. So for instance, I found myself trying to treat a lady in Far North Queensland who had a regular shoulder pain problem, very distressing shoulder pain, which I had been taught could be described as frozen shoulder. She hadn't at that early time gone on to lose considerable amounts of shoulder movement, hadn't stiffened up in the way that is commonly seen, but she had significant amounts of shoulder pain. So I went on and did the kinds of treatments local to the shoulder that I had been taught to do with no success at all for about 2 months. Until one day I happened to be treating her neck for another reason, another complaint that she had mentioned to me, and sure enough discovered that her shoulder pain instantly improved. So I'm sure many of you in my viewing audience have had this same experience. So I used this moment I wondered, wow, they're connected, okay. So I just continued to pursue that line of attack until eventually I found that her shoulder pain could be brought under considerable control. In fact, to the point where ultimately it disappeared within 2 weeks. where previously I'd been treating this shoulder for 3 months or more with no real success at all. But within 2 weeks of about 5 attempts at mobilising her neck, shoulder pain disappeared, didn't come back. I thought it was pretty good. So as a young physio in a far north Queensland place, isolated away from anybody else who I could even say, hey, look what I did, I was chuffed with this. So I just kept on pursuing other pain problems, hoping, of course, that they would turn out in fact to be referred pain just as this had been. Anyway, so commonly I discovered that this is so. So I'm going to suggest to you that many of the kinds of problems that you may be currently treating are in fact referred problems. And if they include things like Achilles tendinosis, pain of the foot of various kinds, even big toe pain, iliotibial band syndrome, or incorrectly called friction syndrome, iliotibial band pain generally, lateral thigh pain, etc. Obviously sciatica, but that's I think a reasonably well-known referred event, but not necessarily well understood, however. The so-called frozen shoulder, a lot of the occasions when people complain of impingement, so-called impingement syndrome of the shoulder. I put forward to you that most of the time, had you explored the prospect that referred pain was taking place, you might discover that impingement in fact wasn't the best explanation at all. So I want to now demonstrate with the help of Gina this method that I call continuous mobilisation. Gina, can you come up and put yourself down here prone for me?
Yeah, would you like my shoes on?
Doesn't matter. No, you're okay. And for the sake of the audience our
Hello.
audience, what do you got underneath here?
Yeah, sorry.
Top? You got a top?
I do.
Oh, cool. Okay. All right. Cool. Now you're perfectly dressed for this.
I'm matching.
Yeah, matching too. Right. So now we can see your neck. And I'm just going to do on this side, and this little gold band shouldn't get in the way too much. Okay. I'm going to put my thumb, here's my left thumb, where I can easily feel some bony prominences, and I'm going to find C5. Okay, this is a lateral mass of the C5, and I'm going to just gently move on it. Tell me if that gives you any pain.
Yes, it's still tight.
Okay.
But
If you were to consider how much pain that would be out of 10, what would you give me?
7.
Okay, that's pretty sore there. Now, the amount of pressure that I'm using right now, the amount of movement pressure, is very small. So it's fair to say that Gina's neck is irritated and that protective behaviour is taking place.
And now it's not sore.
Okay, so within about 10 seconds or so we see a change. Now what I perceive to be is a very slight change in resistance. And tell me, what would you give that now out of 10?
0.
Okay, alright. So what about if we do the same thing to the one just above it?
Yeah, that's equally as sore. That's
Okay.
the first one.
We'll give that a 7 too?
Mm-hmm.
Just going to go around here. Find that as a... Okay. Now if Gina had been complaining of left shoulder pain, and I found that it was consistent with a finding of protective behaviour here in the cervical spine on the left, then by reducing that protective behaviour, we very likely would discover that her shoulder pain improved. Obviously we can infer from that that protective behaviour had been involved in her shoulder pain. How? Well, irritation of spinal nerves, spinal nerve roots.
And the pain has gone away now.
Gone? Okay. So there's about 20 seconds or so, and we have C3.
Yeah, that's the worst.
It's the worst one so far, out of 10.
8.
Coping okay?
Yeah.
All right.
Now it's gone away.
Cool. And there,
That one's not bad.
and a little bit further up.
That's sore.
Okay. Out of 10?
7.
Okay.
That's gone away.
All right. C2. And sometimes as I approach one particular joint from the first angle or first approach that I may do to it, I'll perceive resistance and pain, which will improve. And if I were to change the angle through which I move it, I may find that there's still more pain associated with that, which when improved will generally see an overall further improvement to the general mobility of that joint. State of irritability as well will improve. So some joints I will deliberately move around and approach it from slightly different angles for that reason.
The pain's gone away on that
Okay.
one too.
Now if I want to get to C1, all I need to do is a little bit of left rotation, a little bit of chin tucking down, and not just underneath the occiput, I'll easily find lateral mass there of C1, which is commonly associated with the so-called migraine experience.
That's very sore.
Yeah, out of 10.
7.
Okay.
So
So the amount of pressure I'm using is really just enough to push the skin off a well baked rice pudding.
they won't know what rice pudding is,
Sure they will.
really.
Yeah. Okay, porridge then.
Okay.
Push the skin off your porridge. Yeah. Yeah.
Is it only that much pressure?
Yeah.
It feels like more.
Yeah. This much.
Hmm.
No, not much at all.
Hmm.
Still improving?
Yeah.
Gina has an interesting history. Gina suffered a low back injury, a disc injury, that was considered to be directly related to an incident she had at work, which was several years ago now, and mostly recovered from the injury itself, but had the lingering effects of ongoing protective behaviour. And I've been treating Gina on and off here and there over this last 4 months, 4 months or so. Not continuously, but just a series of 6 treatments followed by a series of a couple more, followed by a series of a couple more every so often, with what appears to be progressive improvement to her tolerance to movement, her appreciation of movement. And as Gina is a yoga teacher, it's obviously very important for her to be able to do the kinds of postures and movements and so forth, and have the fatigue resistance that fits her well for her work purpose. So it does appear that mobilization alone, in combination, I'm sure, with her own self-management routines, yoga, walking, have seen quite a bit of improvement. Excuse me.
The
How's
best
that?
part is to not have pain every day.
Yeah. So the question that's commonly asked is, well, how long does this last? Well, it kind of depends on whether the problem is associated with disease, which is rare, or associated with trauma, which is possible, in which case, okay, trauma has its own sort of special considerations in relation to spinal pain. But for the people who don't have either trauma, significant trauma, or disease as a consideration of the cause, perhaps, of irritation to joints and therefore protective behaviour, then those people do extremely well. The ones, when I say extremely well, I mean that if they were to come to me with a pain problem, in most cases within 3 treatments, it would be significantly improved. In some cases after 1 treatment, that's in other words 30 minutes of mobilisation of the area involved in that pain problem, that spinal pain problem, or that referred pain problem, or both. But an average, I think, would be about 3 treatments. So clearly in some cases people need 6, and a few need 1. Most people fit somewhere in the middle. Now, Gina is a different case because her problem had been associated with trauma and a disc injury, in fact, to L5S1. And when I first began work on Gina's low back, there was quite a bit of irritation, protective behaviour, tightness in general, and so forth, which has, as hoped, progressively decreased and decreased over a period of now a dozen treatments, but over this 4-month period, with ever increasing improvements to mobility and comfort.
Yes, I have gratitude for you every day.
Oh, that's very nice. Right, now let's just go down to the lower part of the cervical spine again. It's not too bad in there.
No, that's good.
Alright. I'm not perceiving any resistance to these movements here. They seem to move better than the ones at the top. I'm going to move my way down now to some thoracic joints. And here I have deliberately positioned my thumb as close to as I can manage over lots and lots of trapezius and other soft tissues, and yet I can still perceive there's a bony element to under my thumb, a lateral mass and a rib, but that the 2 necessary criteria are present, which is resistance to movement and pain. So if pain and resistance drop away, I will conclude that protective behaviour has reduced in this area. What would you give that now?
Maybe a 1 or 2. It's not
Okay.
really that sore.
Okie dokie. Let's go to
Yeah, that
T2.
that one's more tight.
Okay.
So if you were pushing on a very healthy spine,
Mm-hmm.
could you move along every vertebrae and not find pain?
That's right. Yep.
Have you ever found someone
Oh yeah, lots.
that is free of pain on every vertebrae?
Oh, every vertebrae, that's hard. But remember, I have a biased viewpoint because I only see people who complain.
True.
Okay, so, but yes, I certainly have seen people who don't have or have large sections of their spine not involved in protective behaviour, which don't hurt at all with this quite gentle movement.
Hmm.
Okay, how's that now? Go back to that one. What would you give that now?
Maybe a 1. It's hardly, I can hardly feel it.
Okay, alright, so I've seen some changes there and there. Out of 10?
A little more tender, maybe just a touch more, but
Okay.
it's much better than originally.
Uh-huh. Not too bad there?
No, not too bad at all.
Cool, alright. And there? Not too bad?
No.
Alright, let's go this way. Alright, let's start on the other side now. So I'm going to work my way down Gina's neck again, and here we've found some quite clear indications of protective behaviour. Just drop that right arm back, good. This one, drop it, put it in front of you a little bit, just to keep you steady. Okay. So my thumb is now on C2. C2 is immediately below the occiput. You'll notice that my thumb isn't central, PA position, isn't in the gutter between. It's over a little further where I can perceive bony resistance, a lateral mass. Easy to find.
So you're wanting to feel for the bone, the facet?
Yeah, I want to feel some resistance of a bony prominence that's associated with the joint that I'm after. Now, it isn't possible to only move one joint. When I move in this way, I am not just moving one joint. Should be made quite clear, and I don't expect that it would be. Now, what I want to achieve, if I can though, is to sense what resistance takes place, however it might be presented to me, and perceive change in that, along with changes to pain. When I do so and I'm successful, it's associated with pretty much immediate and indeed lasting improvements to active movement and to comfort. So again, I explained that this is associated with a protective behaviour that relates to threat. Alright, how's that now?
That's good.
Okay, I'll go to C3 now. It's only a little bit of a difference inferior to the position I had before.
It's very painful.
Yeah, 8 out of 10, 7 again?
Yeah.
6? Mm-hmm. Right. Goodness, 25 to 3. You take a break? You alright?
Yeah.
Take a break. Demonstrate that it's possible to stretch nerve structures in a method I call ballistic stretching. So if it is perceived that there is a limitation, for instance in this case, to hip-knee flexion, which would stretch both the quadricep muscle, group of muscles, and the femoral nerve, then a quick bouncing type stretch controlled by me is a very effective and quick way to see some releases take place and some improvements to the range of the hip and knee into that stretch movement. And it's associated with a loss of pain to the knee. So if this person had, for instance, knee pain, for instance, patellofemoral pain, which is related to protective behaviour at L3, which I had treated, I might then consider whether or not the femoral nerve also might be tighter than it ought to be. And this is the way that I would go about it. So just relax as best you can. On this occasion, Gina has 2 pillows under her belly, which is really only there because I just treated her back. Ordinarily, if I were doing this by itself, I would take these away. But it doesn't matter because I can still get hip-knee flexion with this movement. Okay, so I'm now in a position you might describe as hip neutral, and I've got Gina's leg there in flexion, and if I pull on it, I can feel some resistance. So I'm going to do that 5 or 6 times and relax. How's it feel?
Tight?
Yeah.
Yeah.
Now when I did that pull, where did you feel? Where was it?
Quad.
Okay. Anything in your knee?
No.
Any other place?
No.
Okay, cool. You're coping okay?
No.
Right, I'm going to do 6 more. Here we go. And relax.
Yeah, all quad.
Okay, and do 6 more. And relax. And last one. Okay. End.
No.
Okay. Is that as far as you can get? Right? Right, in a couple of minutes you'll be able to touch your toes. I want to attempt to stretch your sciatic nerve. Okay, what I'm going to do is get up behind you and I'm going to get you to relax pretty much with your arms down along the side like that. Not do anything to help me. Okay? And keep your feet upright if you can, but your legs straight if you can. Okay? I'm going to do 8 pushes. And if you die, you die. You know. Here we go. Right, arms down along your side. And then just hang there. Okay, here we go. 8 pushes. Here we go. 1, 2, 3, 4, 5, 6, 7, 8. Okay. See if you can
That's
touch your
painful.
toes.
I'm closer.
Closer. Okay, we'll do it again. Might go slightly harder this time. You got coping okay?
Yeah.
1, 2, 3, 4, 5, 6, 7, 8. Good. And touch if you can.
Just.
Yeah, alright. Getting closer all the time. Okay. Here we go again. 1, 2, 3, 4, 5, 6, 7, 8. Beautiful.
I
Bingo,
can
we've
touch.
got touch. So we've got some improvement there.
Yeah.
So what I can say is that muscles generally don't stretch well when you do them ballistically. In fact, they don't stretch at all. All kinds of other soft tissues will, and what I propose is that the ones that have allowed now for Gina to stretch forward into flexion and touch her toes are nerve-related structures and very likely other muscles as well associated with her back. So we're just going to do 2 more, Gina, so we can get a bit more improvement, okay?
I felt that was all nerves.
Okay.
Like it was a nervy feeling, not a muscle feeling.
Mm-hmm. Although I'm going to tell you that it's impossible to tell, right? That you won't be able to tell
I can
because
tell.
all feeling is related to nerves, okay? All feeling. You don't get feeling otherwise. Here we go. 1, 2, 3, 4, 5, 6, 7, 8. Brilliant. A bit
I
faster.
can hold my shoes.
Now, if I go another 10% harder, can you cope, do you think?
Yeah.
Alrighty, here we go. 2, 3, 4, 5, 6, 7, 8. Still further.
Yeah.
One more?
All right.
One more. Here we go. Yeah. I'm
Wow,
not
I can
putting-
hold the bottom of my
Yeah.
shoes.
I'm not putting much pressure through my hand. Most of my pressure is here. Okay, just going to demonstrate without doing it this time, Gina. Drop those arms again. Legs are straight. I'm simply maintaining just a little gentle hold here on her neck, just so she doesn't come back up into my face mostly. Okay, and most of my pressure is my chest. You feel that, Gina, too?
I do.
All on your shoulders, really, isn't it? Okay.
Yeah.
Hang on, just before we roll. I'm going to do a straight leg raise type ballistic stretch, a stretch really of combination of structures including the sciatic nerve. I'm going to get you to put your leg down, right? Let it relax there, that's going to relax as well. Now as I lift up your foot, I want you to let me lift it up,
Okay.
right? I want you to tell me when you begin to feel a bit of tightness at the back if you do it all.
I hamstring a little,
All
but
right?
it's all right.
And when you start again, give me a stop, okay?
When I just start to feel it?
Yep.
Right there.
Okay, all right, so that's about, 40 degrees, not much more, is it? All right, we're going to see what the other side looks like. Same thing, don't help me, just tell me when it starts to be tight.
Right there.
Okay, probably a bit less on that side. Okay, so I'm going to keep going up now. I want you to tell me when I have to stop,
Okay.
because it's too painful, okay?
There.
All right, and where do you feel it? Can you put your finger on it? Okay, so back of your knee, bottom of your hamstring, okay? So that's about 50 degrees. There we go. All right, we'll drop it down again. So now I'm going to do a deliberately painful thing, all right, to your hamstrings, etc. Very much the same way as I did just a moment ago. We want to see what changes, if anything. So I'll get you to rest your foot there on my shoulder. Try not to help me. Okay, I'm going to produce a little bit of stretch here as well. And I'm going to just dip into and out of that painful range. Alright, try not to help me. I want you to tell me when the pain begins.
There.
Okay, so a considerable difference in that first attempt now, where the beginning of the pain is. And tell me where I have to stop.
There.
Okay, so we're going to change there. Let's see if we can change still some more. Alright, again, try not to help me. Are we into pain now?
Yeah.
Good. to help. Relax. Tell me when it starts again.
There.
Okay, so we're still seeing more improvement. Tell me when I have to stop.
There.
Okay. So overall, we're getting improvement with just 2 attempts now. And I just want to look at this one again, just to see if there's
This one's more tight.
something changing. Tell me when it begins.
There.
Okay, and when I have to stop.
There.
Pretty much as before. Okay. So I'm going to keep on going with this one. See what else we can improve. Okay. Coping okay?
Yep.
Alright.
The toes in makes a big
It
difference.
does. Yeah. Okay. Here we go. Good. Alright, tell me when it starts.
There.
Right. And when it has to stop.
There.
Beautiful. Look at how much range that is now.
Yeah.
Okay, so a lot of difference.
Mm.
So what I propose to you is that muscles haven't changed in length, at least not as a response to stretch. Not as a response in a fashion that you'd expect that muscles would ultimately accommodate if you provided them with a continuous stretch experience, which muscles do. What I propose to you is that what's changed is a combination of muscle tone and nerve movement. So an ability for that nerve to allow for tensions to be applied across the nerve itself. And the question mark must still exist, at least it does in my mind, which is where does the majority of that change take place? Does it take place in the brain? Is there a down-regulating experience taking place by virtue of something learned? Or is there something local to the nerve itself? Some people propose that you're pulling on structures that are attached to the nerves and releasing them. I'm not sure. Some propose that you are even stretching nerve fibers themselves. May be true. I suspect though my strongest sense of the reality of neuromuscular pain, nerve-related pain, is that most of the down-regulating effects take place in the brain. Whichever way it goes, it's quite an immediate effect and quite a valuable positive improvement to Gina's ability now to touch her toes. So we should see the same sort of thing happening on the left side as well. Let's have a go. Let's start with where it starts
Right there.
and where it has to go.
There.
All right. I'm not going to go down and test again each time this time.
Okay.
We're going to go straight into it. Okay, I'm just going to do 4 or 5 groups of stretch. And a little bit of a rest in time. That's okay.
So do you have 8 repetitions?
I don't always count. But 8's a good number.
Hmm.
If you want me to count, I'm happy to do that. Make you feel better?
No.
You okay?
No, I don't mind not having numbers.
Okay.
But 8 is a good number.
1, 2, 3, 4, 5, 6, 7, 8. Just going to give it a little rest.
8 is infinity.
Yeah, is that right?
Good fortune.
Okay. Alright, last one. Okay. Alright, tell me when it starts.
Feels like a different leg.
No limit.
There.
Right.
Just now all the way at the top.
Okay. So once again we've seen an effective change to perceived hamstring, which is sciatic pain, with short range ballistic stretches of Gina's sacroiliac joints as best I can. And this is the stalk test or the march test. So I'm going to put my thumbs on her PSISs right here. Nice easy landmarks to find. Gina, I'm going to get you to lift one knee toward your chest, slowly up, and drop it down again. What I notice is that the level of my thumbs remains the same. Do that same movement again, and down again. And do the same with the left, and down again. Now I associate this with no movement of either of those sacroiliac joints. Were I to be seeing nutation, counter nutation, then I'd be seeing that associated with flexion. Okay, let's do something about it. Anytime you're not sure. So I'm just going to lock Gina's right knee now into my hip and knee like so. And just, actually I'll get you to just put it there. And I'm going to anchor my hand here and try, if I can, to put my other one on Gina's ischium. My intention is, if I can, to try and rotate that rearwards and imitate normal SIJ movement. It's going to be a bit painful, especially here, okay? Tell me to stop if you need to, and do as many as I can. I might even be able to see some movement, maybe. Alright, that takes a lot of effort. I can do the same thing from the other side. I'll just demonstrate. Actually, if you spin yourself over, I'll do